this talk. Professor Ponco Birowo is a professor of urology in Faculty of Medicine, Universities Indonesia, Cipto Mangunkusumo Hospital, Indonesia, in which it is the top-ranking university and largest teaching hospital in Indonesia. His special interests include andrology, endourology, and transplantation urology. He is currently the Vice President of the Indonesia Urology Association and the Director of Urology Training Program in University in Indonesia. He is also the former President of Indonesian Society of Endourologists from 2019 to 2021. Is actively involved in several international organizations, namely European Society for Sexual Medicine and Society International de Urologies and Global Andrology Forum. And today he will give talk on the lectures on the title of Updates on Surgical Sperm Retrieval Techniques. Please welcome Professor Ponco Birowo.
Thank you very much, Professor. Ladies and gentlemen, first of all, thank you very much for the committee who invited me in this prestigious meeting. Today I would like to give a presentation about the updates on surgical sperm retrieval techniques. Before I start my presentation, may I know how many urologists in this room? Oh, it's quite surprising that most of you are OBGYN, right? Okay, thank you. Okay, first of all, I have no potential conflict of interest to disclose. The table of contents of my presentation today is about introduction, history of sperm retrieval techniques, and future direction and take-home messages. Sperm retrieval is a crucial procedure in addressing male infertility. As we know, if you want to make a baby, not only a female factor is important, but also the male factor also important. So sperm retrieval is designed to collect sperm directly from the male reproductive system, that is a testicle or epididymis, when natural ejaculation is not viable or effective. For example, if a man cannot do ejaculation at the time the woman is ready for ovum pickup, you tell the man you have to ejaculate. Sometimes the patient cannot do erection at all. So it means you have to refer us for the sperm retrieval. This is the timeline or history about the sperm retrieval. Yeah. First of all, in 1978, the sperm was used for IVF the first time. And then 1980s, this is the first time they used the sperm from epididymis. Yeah. And then 1992, the sperm was used for ICSI, intracytoplasmic sperm injection. And then 1993, this is the first use of testicular sperm for IVF. And then 1995, testicular sperm used in the non-obstructive azoospermia in IVF ICSI. And 1998, this is the first description of the micro TC. If the patient came to us for the sperm retrieval, it is our job to make the successful rate is also high. We cannot directly send the patient to the operating theater for the sperm retrieval unless we have to make sure that there is no anything else that we can do to repair the condition of the patient. So we have to check the patient first. Is there any possibility that the patient not have to go to the operating theater? For example, if the patient have a hormonal imbalance. The first lecture, Professor Koji already mentioned about the possibility for the patient to have a hormonal therapy first before the sperm retrieval. We have to check whether there is hypogonadism in the patient. So if the patient has the low FSH, low LH and also low testosterone, if we do the sperm retrieval, then we will find nothing. Yeah. So 30% of the non-obstructive azoospermia is hypogonadism. If we treat them with this hormone therapy, without any sperm retrieval, maybe we can have chance the patient to have sperm in the ejaculation. The second is we have suggested to do the ultrasound to check the presence of varicocele. Although we can do check the varicocele using our physical examination, but sometimes the patient need more confidence to show that you have the varicocele. Yeah. So in the ultrasound, beside the varicocele, we also check whether the volume of the testicle. The volume of testicle can predict the successful rate when we do the sperm retrieval. So if the hormonal imbalance and the varicocele is present, it is advisable to repair them or to fix them first. And then we make sure that the semen analysis, there is no sperm by doing the centrifugation. And then we can also check the Y chromosome microdeletion. If the patient have the microdeletion in azoospermia factor A and B, then the possibility to get sperm during the sperm retrieval is very, very, very low. So, what is the present sperm retrieval techniques at the moment? So, the indication of the sperm retrieval, the most important is azoospermia. We can divide it into two: obstructive azoospermia and non-obstructive azoospermia. We have to consider also the genetic consideration. Yesterday we have a very nice presentation about the genetic problem in male infertility. Also, we can see whether there is a history of vasectomy or not, or another surgical complication. Is there any ejaculatory dysfunction? For example, premature ejaculation or retrograde ejaculation. If the problem is retrograde ejaculation, then we don't have to do the operation. Just do the semen analysis in the urine after the ejaculation, and we can find the homotized sperm. And then in the patient with the history of cancer, the patient had the cancer in another organ, have chemotherapy, radiation, and before they did the cancer treatment, there is no bank of sperm. Bank sperm is not available. Then we have to do the sperm retrieval in those kind of the patient. In general, the sperm retrieval techniques, there are two: sperm retrieval and fine needle mapping. There are percutaneous sperm aspiration, microepididymal sperm aspiration, testicular sperm aspiration, conventional testicular sperm extraction, micro TC, and single site sperm retrieval. And the FNA mapping, fine needle aspiration mapping, is not considered as a sperm retrieval because if we find sperm, the number of sperm is very low and then we cannot freeze it. And there is no guarantee that we can extract the sperm. First is the percutaneous or aspiration. Aspiration can be from the epididymal and also from the testicular. The percutaneous epididymal sperm aspiration is a very nice procedure for the urologist. Sometimes if the patient is under general anesthesia, before the anesthesiologist is finished making the tube, we already finished the operation. Only 5-10 minutes is finished, and we can also do it in the local anesthesia. It's very nice. But I have to give a message. One of my OBGYN in my hospital think that it's very easy doing that. And suddenly someday there is a problem, there was a problem, he hit the artery. So the testicle is become as big as ball. It's a nightmare for the OBGYN if that happened to your patient. So it's better to refer to the urologist. That's the important message. So if there is enlargement in the epididymal, 90% of the obstetrical sperm can find sperm. Very easy. The patient happy, there is no incision, the doctor happy, everybody is happy. The hospital also happy because we use the operating theater in the very short time. This is the importance of the size of the testicle is important because if the size of testicle is more than 20 millimeter, then the success rate is 61%. If the testicle volume is less than 20, then success rate is 27.5%. So that's why ultrasound before the operating theater is also important. This is how do I do the percutaneous sperm aspiration. It's very fast and very easy. It is true that even the anesthesiologist said that it's more difficult to find vein or artery when you're doing the aspiration, but this is we are finished. We can see the fluid is become dark. The second is the testicular sperm aspiration. It means that we aspirate the testicle directly. This is the sperm retrieval rate is 11 until 47%. It's minimal risk. It's bleeding only 1%. And then we can do opening the epididymis. This is the gold standard for obstructive azoospermia. We open the epididymis and do the aspiration also. But there is a incision in the duodenal scrotum. This is the testicular sperm extraction. This is the C is referred to the conventional one. But the conventional TC is not popular anymore. We use the micro TC. We do not do micro TC unless there is no microscope available in the clinic or the hospital. This is the gold standard for non-obstructive azoospermia. We can compare the sperm retrieval rate in micro TC is 15 until 20% better than testicular sperm extraction. The disadvantage of the micro TC is that we need the microscope and the surgeon should be trained for the microsurgery. This is the advantage of the microthesis. Disadvantage is more specialist expertise, longer procedure, and higher operating cost. This is the single site sperm retrieval. I think one of the best in the world doing this is Professor Rubinsa. He is here. There is advantage and disadvantage, of course. Less traumatic than testicle biopsy and microthesis. This is not suitable for the small fibrotic or atrophic testes and less effective compared to microthesis for the focal spermatogenesis. Because the single site sperm retrieval is kind of blunt. We do not looking the sperm in the specific area. This is the diameter of testicle, also important here. This is more than if the more than 3 cc and in the sperm retrieval rate is 84%. The next is biopsy mapping. It's like if we do not know where is the water, then we have difficulty. It's like when we are looking where is the sperm, we don't know. But if we do the mapping, maybe we can find, oh, here is the. It's very difficult if we do the aspiration here. Maybe we do not find the sperm. But if we do the correct place, then we can find the sperm. Yeah. So the sperm, the testicle can be divided into the 36, 18 in the left, and 18 in the right side. So we do the fine needle aspiration, check which one is in this area is present, the sperm is present or not. Okay. So why 18, not 20 or 15? It is already studied. If more than 18, the number of success is not increased. So this is the PESA TESA is until 18 until 48%. MESA or TESA is 44%. Biopsy is and microTESA is 20% better than TESA. This is all procedure performed without biopsy mapping. Okay. So the purpose of biopsy mapping to find out the exact location of sperm production. It's like if you want to see the mango dry mango, maybe we have to find here in Manila. If you're looking in Taiwan or another place, we cannot find the dry mango. But if we know that the mango dry is here around the Philippines, then we will concentrate in this area. So after we do the biopsy mapping, if we only find one area, and then we have to do the microTESA. But if we find two, we can do the conventional TESA. But if we find in a more area, then we can do the aspiration only. This is very easy also, doing the fixation and doing the side marking, and then we do the series, and then we can do the aspiration. So we know exactly where is the sperm is, or this in the area, for example, this is 20, 21, 24, and 25. In the right side is in the number this one. And then when we do the microTESA, then we will concentrate doing the exploration in this area. Rather than we in this empty area, we know that if we do exploration in this area, we will not find the sperm. We can also combine it between the biopsy mapping and also microTESA. This is the equipment. And then we can do the it is the surgery, and then we have to make fixation the mapping biopsy in the left testicle. We have to fix the testicle. Then we have to make marking, and then we do the aspiration with the gun biopsy, and then after that, that five area is checked by the embryologist. Which one from the 5 area is the sperm is present, and then we do the microTESA. The microTESA, sorry. And then if we found sperm, we can do the, in this patient we found only one sperm, and then we do the laser assistant. This is once again, before we do the operation, is there any hormonal problem or not? If the patient with hypergonadotropic, hormone therapy is not improve the sperm retrieval. But also in the patient with eugonada, the evidence is low quality of moderate to high bias. But if the patient hypogonadotropic, system, and then it's very highly advisable to do the hormonal therapy first before we do the sperm retrieval. But we have to remember that if we do the hormonal therapy or the varicocele repair, it takes time. It's not instant procedure. We have to wait at least 3 months. Yeah. Usually we can wait until 9 months or even 1 year. So can we improve the prediction before the sperm retrieval? If there is sperm and vascular, we do the repair, sperm varicocele repair. Diet, antioxidant, yes or no? I give it to you whether we are going to antioxidant or not, and also we can do the regular exercise. Once again, it's not a instant procedure. The next is varicocele. Varicocele can increase the temperature of scrotum, and there is reflux. The reflux causing the hypoxia and oxidative stress in the testicle. Okay. This condition can impair the testicle function, and then varicocele repair can improve testicular function. So I have a study in my hospital. If the patient non-azoospermia with varicocele, if we treat the varicocele first, the possibility to find the motile sperm after in the sperm retrieval is 29%, 69%. If the varicocele is not repaired, and then the possibility is 27%. And the varicocele repair is more advisable in the very higher efficiency. This is the future direction. The ultrasound, we can see the retro-testic thickness and the self-wave elastography. So if the testicular volume and the retro-testic thickness increase, we can find the prediction is better. Yeah. This is another equipment. So we do not need the microscope. This is, we call it all-eye. This is more comfortable and natural working position, reduce the need for frequent repositioning, allow multiple viewers to observe the procedure in 3D. So the disadvantage of microscope is the person who see the operation field is only the operator and the assistant. Okay. The limitation is high cost. I think this is still new. We haven't used this as a procedure, normal procedure. And the next is the robotic. Yeah. So doing the sperm retrieval using robot was done by Professor Parikatil and Gudelum group. But if you pay attention, they use it only 2009 and 2012. After that, there is no publication. The benefit is tissue handling, section, but absolutely it will increase the cost. Yeah. If they pay the robot, maybe they cannot do the IVF. But however, it is for my opinion. Maybe someday, if the artificial intelligence can study the best surgeon doing, in this area he or she took the sperm, and this area is not. Maybe someday the exact place can be increased using the artificial intelligence. But this is now is 2024. The publication is 2030. It's quite long. So as take-home message. So we can choose the sperm retrieval techniques based the individual condition and fertility goals, and apply advanced microsurgical tools and robotic if necessary, possible, and constant collaboration among specialists to optimize treatment, manage expectation, and improve IRT success rate. The last is I would like to invite you all to Bali this year in September. Then there is a Urologic Association Asia Congress. Thank you very much for your attention.
All right, thank you very much, Professor Birowo. And now I would like to invite all three speakers to the stage, and then we open the floor for all the audience who have any comments or questions to the speakers. We will have 15 minutes for Q&A.
Thank you. I'm a gynecologist, so of course my view is much less, knowledge is much less than yours. But in a patient with only low count, would chronicity or levels of health? Again, with or without antibiotics.
So the question goes to everyone, right?
Okay, thank you for that good question. So for patients with low sperm levels, abnormal sperm levels, clomiphene, of course, is not FDA approved, but I think you know that it has been used extensively. Urologists have been using it. I personally have been using it, and what we notice is that testosterone levels can increase based on the usage of clomiphene, and therefore sometimes we do see also improvement in the sperm parameters as well. So my personal practice, yes, when a patient has, especially if it's a hypogonadotrophic hypogonadism, low testosterone levels, with poor infertility, I do give clomiphene for these patients. Whether to add on the antioxidants, you will come to the question of cost. If they can afford it, then I would say yes, I would promote them using some of these antioxidants to help them to improve their chances of getting better results.
Do you give just 25 milligram every day, or you give 50 milligram 25 days, break for 5 days, and again give 25? That's what some urologists are doing.
Okay, with the others will be able to answer. My personal experience is I start off with 25 milligram, and surprisingly with 25 milligram once a day, I do get good results actually. Yeah, if it's not, then I may increase it to 50 milligram once a day.
This clomiphene is just approved by government in Japan. So in case of NOA, it's not effective. But in case of low testosterone, for example, 300 nanograms per deciliter, and also low LH, around 3.5 or 3, and then 3 or 3.5, it's very effective. But the patient showing that hormonal parameter is around 10% in my practice. So, but in that case, the clomiphene is very good.
Yeah, I agree also, but remember we have also to find another factors can causing the low concentration of sperm. For example, is varicocele, infection or something.
All right, the mic can please.
Thank you. The question is for Dr. Birowo. For your varicocele patients, for patients with non-obstructive azoospermia, did you have a look at their histology when you had those positive findings?
Yes, there is. We do the histology examination also. The Johnson score is higher compared to the patient with the repair varicocele compared to non-repair varicocele.
Sorry, what was the histology findings? Were they non-obstructive patients? Were they hypospermatogenesis or sertoli celoni?
Yeah. There is some percentage of the SCOS, SCOS and also the
Maturation arrest.
maturation arrest also. Most of them is maturation arrest.
In all subgroups,
Yes, correct.
repairing varicocele helped.
Yeah.
Okay, excellent.
But
And
the
this-
problem, the disadvantage is I don't have the histology examination before so we cannot compare before and after the varicocele repair.
So during varicocele repair, do you take a biopsy for histo?
No.
No, you do not. Thank you.
I have a question for Dr. Shirashi. When you're doing the hormone therapy for the NOA case, will you evaluate the chromosome or Y chromosome microdeletion before you give the hormone?
Sure. Basically, my hormonal protocol is after correct microdeletion. So at the time of first microdeletion, I of course do Y chromosome check and G1.
Basically, you just give them hormone after you fail to microdeletion, right?
Because there is no guarantee to impair or to stimulate testosterone by using hormone therapy. So I opt to do hormone therapy after correct microdeletion.
Okay, just makes things clear. And how about even the antioxidant do not have the help for the sperm quality or function? How about the aged person? Do they get any benefit? Because I saw you are a member for the aged man. So any kind of benefit from the antioxidant for the people, men, not for the sperm.
Yeah, of course, yes. Antioxidants for other conditions as well, for other diseases has been used and has been studied extensively as well. So there is evidence also to show that antioxidants do help in other organs as well, especially aging men, aging people as well. It can help even in, CoQ10 has also been used by cardiologists for protection of the heart because it is anti-inflammatory and antioxidant, reducing the oxidative stress. So yes, antioxidants not only for infertility but for general health in general as well.
Hi, Uma from Malaysia. Thank you for the excellent talk. This question is for Prof. Shirashi. You mentioned there is no correlation between serum testosterone and intratesticular testosterone levels. So if I were to start the patient on hormonal treatment, how do I determine what is the duration of the treatment before I go in for microdosing?
It's a very different problem, but we don't evaluate the testosterone in the kind technique. So I recommend to do hormone therapy at least after 6 months after first microdosing, because the testicular parenchyma is heavy during these 6 months. So there's no evidence, but I would like to do, let's say, after 6 months. But in my practice, the average duration for hormone therapy is 1 year, because patients are thinking about what they are doing.
So there is no blood test that is required to look at any levels at all. You just take a cutoff of 1 year before going.
After 1 year,
For hormonal treatment, before doing a microdosing,
Yeah.
you will put the patient on 6 months to a year, regardless of the testosterone levels.
yes.
Okay.
Yeah. In my practice, the hormone therapy is very challenging because we have to inject the patient 3 times a week for 6 months until 12 months. Before we start, the most important is the commitment of the patient and also the logistic, I mean the money, because it's not covered by national health insurance. So we have to ask patient, are you ready 3 times a week for 1 year doing injection? If he said yes, then we can continue. If the logistic only for 3 months or 2 months, then don't wait, we direct to the microinjection.
Alright, so I have a question to Professor Poncho. According to what you just answered, let me continue on to that. Well, do you see any difference between the use of the gonadotropin versus clomiphene? Because in terms of convenience, in terms of cost, I would say that if it's going to be like a year of gonadotropin versus a year of the clomiphene citrate, the cost will be a bit different, and also in terms of convenience and patient acceptance will be totally different. So, in your experience, do you have any preference on gonadotropin versus clomiphene citrate or aromatase inhibitors?
Yeah, in the hypo patient, I think I will use the gonadotropin rather than the clomiphene citrate.
So let me have questions. All right, please.
Regarding to which better was chlomine and gonadotropin, in patients with NOA, chlomine does not do anything because it's a very strictly regulated testicular and some feature defective. So only high dose gonadotropin will be able to stimulate testis.
Alright, so let me ask Professor Christopher Ho about the antioxidant. It seems that with all the publication that you have mentioned, there is mixed report on different types of antioxidants, in which you have like multiple types of antioxidants in which they have different mechanisms. Okay, but it seems that when someone is given antioxidant, you're going to bombard them with more than one type of antioxidant. So, and also for the sperm, I would say that to me, study in andrology will be very different, because in terms of the variations of the sperm parameters, it has a big variation, so it is quite difficult to compare. I mean, for people who have poor sperm quality to see the improvement. But if you restrict or limit only for those who have the sperm DNA fragmentations, okay, I would say that the variation could be somewhat smaller. Do you see any difference in different type of the antioxidant, or do you see any benefits on the treatment of the antioxidant?
Yeah, okay, so that's a good question regarding the different types of antioxidants and whether it's beneficial for the different types of sperm abnormality. So, again, the studies have not really conclusively shown which antioxidant works for which problem. But if we think about it, things like CoQ10 it does improve energy, so it may be positive for patients with immortality problem in the sperm, as shown by the paper by Professor Lee, who actually showed that CoQ10 is actually useful for patients with sperm mortality problems, and others has not been conclusively shown yet. So we still need more studies to actually prove. So there's no recommendation yet that can be given by any of the guidelines, even in Europe or US as well.
This is my personal opinion, why the antioxidant give the very different result in the different study. Because it's 30% of the male infertility is idiopathic. We don't know the mechanism. So if we give the antioxidant, it means that maybe we are hopeless. We don't know what else to do. Then we give the antioxidant.
I love that answer, because antioxidants to me seems to be something like hopeless medicating because it seems like it is introduced to everyone, poor aware and reserve, poor sperm when you cannot really explain and don't really know what to do, and you don't even know which antioxidant is the best, so you bombard them with 5 different types of antioxidant to cover for all different mechanisms. So, well, I love your answer. All right, so, well, is there any more questions from the audience? Okay, thank you everyone. Thank you so much for wonderful lectures and for